We know based on ECOG 3200 that patients who did not receive bevacizumab in the first-line setting and even progressed in the first-line setting, that there was an improvement in response rate, in progression-free survival, and in overall survival with the addition of bevacizumab. In this particular patient, we do not even have progression on FOLFOX chemotherapy. We have stable disease. Therefore, I believe that the addition of bevacizumab is important in this setting in prolonging her progression-free survival, not only based on the fact that it is helpful in a second-line treatment if we're considering this somehow to be not a great response to FOLFOX, but also based on first-line chemotherapy studies, namely the IFL clinical trial, IFL Avastin versus IFL, where we see improvement in response rate, progression-free survival, and overall survival, and also based on the clinical trial in 016966 study, which showed that adding bevacizumab Avastin to oxaliplatin-based therapy improves progression-free survival. In this particular patient, where I cannot perform surgery and I cannot downstage to resection, would be to use a maintenance chemotherapy that delays the progression-free survival as long as possible, that is well tolerated with minimal side effect, and therefore I will add bevacizumab to 5-FU. In support of this strategy is also the CAIRO-3 clinical trial, which has looked at maintenance chemotherapy with fluoropyrimidine plus bevacizumab after an induction chemotherapy with oxaliplatin-based chemotherapy plus bevacizumab. In that particular setting, there was also a delay in progression-free survival and treatment failure. So I think my number one choice in this patient would be maintenance with 5-FU and bevacizumab.